Welcome back to Crowned Black Heroes, where we uncover the stories that changed the course of medical history, but were nearly forgotten. Today I'm going to tell you about a night in 1893 when a black surgeon performed what many consider the most daring medical procedure of the 19th century. A young man lay dying on an operating table, a knife wound to his chest threatening to end his life within minutes. There were no x-rays to see inside his body. There were no antibiotics to fight infection. There were no blood transfusions available if he bled out. And the medical establishment believed that touching the human heart during surgery meant certain death for the patient. But one surgeon, a brilliant black doctor who had already broken barrier after barrier in a deeply segregated America, decided that the rules needed to be rewritten. What happened in that operating room on a sweltering Chicago night would change medicine forever. That subscribe button and turn on notifications because we bring you these incredible, untold stories every single week. And if this story amazes you, if it makes you realize how much history you weren't taught, smash that like button and drop a comment telling me what you think. Now let's talk about Dr. Daniel Hale Williams and the night he opened a man's chest, touched his beating heart, and did what the entire medical world said was impossible. Chicago is in the grip of a brutal summer heat wave. The city is hosting the world's Columbian Exposition, a massive World's Fair celebrating the 400th anniversary of Columbus's arrival in the Americas. Millions of visitors are flooding into Chicago, marveling at the newest technologies and innovations. Electric lights illuminate the White City, as the fairgrounds are called. The first Ferris wheel towers over the crowds. It's an era of optimism and progress, at least for white America. But for black Americans, even in northern cities like Chicago, life is constrained by rigid segregation and discrimination. Most hospitals refuse to treat black patients. Medical schools refuse to train black doctors. And black physicians who manage to get trained find themselves with almost nowhere to practice their skills. This is the world that Dr. Daniel Hale Williams has been fighting against his entire professional life. And on this particular night, that fight is about to take on literal life and death stakes. Daniel Hale Williams was born in 1856 in Hollidaysburg, Pennsylvania, just 9 years before the end of the Civil War. His father, Daniel, was the fifth of 7 children, and his early life was marked by tragedy and instability. When Daniel was only 11 years old, his father died of tuberculosis, and his mother, unable to care for all her children, sent them to live with various relatives and friends. Young Daniel ended up apprenticed to a shoemaker in Baltimore, then later in Wisconsin. But this wasn't the life Daniel wanted. He had bigger dreams, ambitions that seemed almost impossible for a young black man in post-Civil War America. He saw an opportunity in barbering, his father's profession, and learned the trade. But while cutting hair in Wisconsin, Daniel met a man who would change his life trajectory entirely. That man was Henry Palmer, a prominent white surgeon who saw something special in the intelligent, curious young black man who cut his hair. Palmer took an interest in Daniel's education and eventually offered him something extraordinary: the chance to apprentice in his medical practice. In the 1870s, most doctors didn't attend medical school as we understand it today, through observation and practice. For a black young man, even getting such an apprenticeship was nearly impossible. White doctors didn't take black apprentices. But Palmer was different, and he recognized brilliance when he saw it. For 2 years, Daniel Williams worked in Palmer's office, learning anatomy, physiology, surgical techniques, and the art of diagnosis. He read every medical text he could find. He observed surgeries. He asked endless questions. He discovered that he had a natural gift for medicine, particularly for surgery, which required steady hands, quick thinking, the ability to make life or death decisions under intense pressure. Palmer encouraged Williams to pursue formal medical education, and in 1880, at age 23, Williams enrolled in the Chicago Medical College, which would later become Northwestern University Medical School. Medical school in 1880 was nothing like today. The curriculum was shorter, usually just 2 years. Standards were less rigorous. For a black student, even gaining admission was an achievement, and thriving there was another matter entirely. Williams faced discrimination from fellow students and some faculty. He was excluded from social events. He had to work twice as hard to receive half the recognition, but he persevered, driven by an almost obsessive commitment to excellence. He understood that as a black physician, he would be judged not just as an individual, but as a representative of his entire race. Any failure would be used as evidence that black people were intellectually inferior. Any success would challenge the racist pseudoscience that dominated American medicine at the time. Williams graduated in 1883 with his medical degree, one of the very few black physicians in America. But getting the degree was only the first hurdle, and we had to find somewhere to practice. Most hospitals in Chicago and across America operated under strict racial segregation. They would not grant black physicians admitting privileges, meaning black doctors couldn't bring their patients to hospitals for surgery or advanced care. Black patients were often refused treatment entirely or relegated to basement wards with the worst conditions. This wasn't just discrimination, it was a public health crisis. Black people were dying from conditions that could have been treated if they had access to proper medical facilities. Williams opened his practice on Chicago's South Side, serving the black community and anyone else who would see a black doctor. He quickly gained a reputation for exceptional skill, particularly in surgery, but he chafed against the limitations imposed by the lack of hospital access. He couldn't perform complex surgeries in his office, couldn't provide the level of care he knew his patients needed and deserved. And he watched as black patients died from treatable conditions because no hospital would admit them, so Williams decided to do something that seemed almost impossible. He would build his own hospital. In 1891, with the help of prominent members of Chicago's black community and some sympathetic white allies, Williams founded Provident Hospital and Training School. This was revolutionary in multiple ways. First, it was open to patients of all races. In an era of rigid segregation, Provident was integrated, treating black and white patients side by side. Second, it included a nursing school that trained black women for professional nursing careers. At the time, most nursing schools excluded black women entirely. Third, and most importantly for the medical profession, it provided a place where black physicians could practice, teach, and advance their skills. Provident Hospital was small, just 12 beds initially, located in a converted house on Chicago's South Side, but it represented hope, possibility, and a direct challenge to the segregated medical system. Williams served as chief surgeon and poured his energy into making Provident a center of medical excellence. He was determined to prove that black medical professionals, given the opportunity, could match or exceed the standards of any white institution. And that brings us to that hot July night in 1893, when all of Williams's skill, experience. James Cornish was a 24-year-old black man who worked as an expressman, essentially a delivery person in Chicago. On the evening of July 9, 1893, Cornish got into an altercation at a saloon on State Street. The details of the fight are lost to history, a kind of minor dispute fueled by alcohol and hot tempers that usually ends with nothing more than bruised egos and maybe a black eye. But this fight ended differently. A man named Edward James pulled a knife and stabbed Cornish in the chest, just left of his breastbone. The knife penetrated deep and Cornish collapsed. Someone called for help, and Cornish was rushed to the nearest hospital that would treat a black patient. Provident Hospital, the institution Williams had founded just 2 years earlier. When Cornish arrived at Provident, he was conscious but in obvious distress. Blood soaked through his shirt. He was having difficulty breathing. The knife had penetrated Cornish's chest cavity. That much was obvious from the location and depth of the wound. But the critical question was what internal damage had been done. Had the knife pierced Cornish's lung, his heart, major blood vessels? Without X-rays, which wouldn't be discovered for another 2 years, Williams had no way to see inside Cornish's chest. He had only his knowledge of anatomy, his experience, and his hands to guide him. Williams did what he could with conservative treatment. He cleaned and dressed the external wound. He monitored Cornish's vital signs. He watched and waited, hoping that the damage was minimal and that the body's natural healing would be sufficient. For 24 hours, Cornish remained stable, but on the morning of July 10th, his condition began to deteriorate. He developed a fever, his pulse became rapid and weak. Most alarming, he showed signs of cardiac tamponade, a condition where blood or fluid accumulates in the pericardium, the membranous sac surrounding the heart. As fluid builds up in this sac, it compresses the heart, preventing it from beating effectively. Without intervention, cardiac tamponade is fatal. The heart simply can't pump blood, and the patient dies. Williams faced an impossible decision. In 1893, the medical consensus was absolute and unambiguous. You do not operate on the heart or the structures immediately surrounding it. The heart was considered untouchable. Numerous surgeons had attempted cardiac procedures over the centuries, and almost all had resulted. In the patient's death, medical literature was filled with warnings and case studies documenting these failures. Opening the chest cavity itself was incredibly dangerous. The risk of infection was enormous because this was before antibiotics. The risk of the patient bleeding to death was high because blood transfusions were not yet reliably available. And even if you could overcome those obstacles, touching or manipulating the heart was believed to cause immediate cardiac arrest. Conventional medical wisdom was clear. James Cornish would die. But at least he would die without his doctor violating the fundamental rules of surgical practice. Daniel Hale Williams looked at James Cornish dying on that hospital bed and made a choice that would define his legacy. He would operate. He would open Cornish's chest. He would explore the wound. And if necessary, he would do what no surgeon in America had successfully done before. He would repair damage to the structures surrounding the heart itself. Williams assembled a surgical team. This included Dr. George Hull, another black physician on staff at Provident, several nurses from the training school, and a handful of other doctors who gathered to observe what everyone expected would be a desperate, probably futile attempt to save Cornish's life. There was no surgical theater as we would recognize it today. The operating room was a simple room with a table, some basic instruments, and whatever light could be gathered from lamps and the windows. Anesthesia in 1893 meant chloroform or ether, dangerous substances that could kill the patient if administered incorrectly. Williams had Cornish anesthetized and positioned on the operating table. He sterilized his instruments as best he could with the knowledge available at the time. Joseph Lister had introduced antiseptic surgery in the 1860s, and Williams was meticulous about sterilization, boiling his instruments and using carbolic acid solutions to reduce the risk of infection. And with steady hands and absolute focus, Williams made his first incision. He cut through the skin and muscle of Cornish's chest, carefully controlling bleeding as he went. The human chest is a complex architecture of ribs, muscles, and connective tissue, all designed to protect the vital organs within. Williams had to navigate this anatomy with precision, creating access to the chest cavity without causing additional damage. Once through the chest, Williams could see the pericardium, the fibrous sac surrounding the heart, and he could see that his diagnosis was correct. There was blood accumulating in the pericardial space, compressing the heart. The knife wound had penetrated not just Cornish's chest, but had actually cut into the pericardium itself. Williams could see the heart beating beneath the pericardium, could see the accumulating blood threatening to stop that beating entirely. Every surgeon observing believed that if Williams opened the pericardium, if he actually touched the heart, Cornish would die instantly. The heart would stop, or it would go into an uncontrollable rhythm, or some other catastrophic event would occur. This was the received wisdom, supported by decades of surgical experience. But Williams, looking at that beating heart and that dying patient, decided that the received wisdom was wrong. He made a small incision in the pericardium. The accumulated blood drained out, immediately relieving some of the pressure on Cornish's heart. Williams examined the pericardial tear more closely. The knife had created a laceration approximately 1¼ inches long in the pericardium. It was bleeding slowly but steadily, and if left unrepaired, would continue to fill with blood even after Williams closed the chest. So Williams did what conventional wisdom said was impossible. He took a needle and surgical thread, and he sutured the pericardium, sewed closed. The tear in the sac surrounding James Cornish's beating heart. His hands were steady despite the pressure. Stitches were precise, despite the knowledge that he was operating in territory that no American surgeon had successfully navigated. The doctors observing held their breath. The nurses stood frozen, and James Cornish's heart continued to beat. Williams examined the heart itself more closely. The knife appeared to have nicked one of the small blood vessels on the heart's surface, but the heart muscle itself was undamaged. Williams decided not to suture the heart directly, judging that the small vessel injury would heal on its own and that the risk of suturing the heart muscle outweighed the potential benefit. This judgment, this ability to assess risk and benefit in real time with imperfect information, is what separates great surgeons from merely competent ones. Williams cleaned the chest cavity as thoroughly as possible, knowing that infection was one of the greatest risks in the days ahead. Then he closed Cornish's chest, layer by layer, suturing muscle and skin until the wound was sealed. The surgery had taken approximately 90 minutes. Cornish was alive. His heart was beating regularly. His breathing, though labored, was stronger than before the surgery. But now came the most dangerous period: recovery. In 1893, there were no antibiotics. If infection set in, there was almost nothing Williams could do. There were no blood transfusions. If Cornish bled internally, there was no way to monitor his heart function electronically, no EKG machines, no ultrasound. Williams and his nursing staff would have to rely on careful observation, taking Cornish's pulse regularly, monitoring his temperature, watching for any signs of complication. For the first 48 hours after surgery, Cornish remained in critical condition. He developed a fever, which could indicate infection or could simply be the body's response to the massive trauma of having his chest opened. Williams changed his dressings daily, watching for any signs of wound infection. He listened to Cornish's heart and lungs multiple times each day. He barely slept, staying close to the hospital, ready to intervene if Cornish's condition deteriorated. The other doctors who had observed the surgery waited, expecting Cornish to die, and Williams's bold experiment to end in tragedy that would vindicate the conventional wisdom about cardiac surgery. But James Cornish didn't die. His fever came down. His wound began to heal. Strength gradually returned. After 51 days in Provident Hospital, James Cornish walked out alive and well. He returned to work. He lived a normal life. He survived for more than 20 years after the surgery, eventually dying of a completely unrelated cause. Hale Williams had opened a human chest, repaired damage to the pericardium, and the patient had not only survived, but had fully recovered. This should have been front-page news. Should have made Williams world famous overnight. This should have earned him immediate recognition as one of the great surgical pioneers of his era. But remember, this is 1893 in America. Williams is a black surgeon. Cornish is a black patient. And the surgery took place in a small hospital serving Chicago's black community. The mainstream medical establishment took very little notice. Williams did present his case to medical societies. He published a report of the surgery in a medical journal in March 1897, nearly 4 years after the operation. The report was clinical and understated, as medical writing tends to be, but it documented clearly what Williams had done and the successful outcome. Some surgeons recognized the significance of Williams's achievements. He received invitations to speak at medical conferences. His reputation grew within certain circles, but he never received the level of recognition that a white surgeon would have received for the same achievement. In fact, for many years, there was debate and controversy about whether Williams had truly performed the first successful cardiac surgery. Some medical historians argued that other surgeons had performed similar operations earlier, though without the successful outcomes Williams achieved. Others claimed that Williams's procedure wasn't technically cardiac surgery because he hadn't sutured the heart muscle itself, only the pericardium. These debates, often tinged with racism, minimized Williams's achievement and denied him his rightful place in medical history. It wasn't until decades later that historians definitively established that Williams had indeed performed the first successful open-chest cardiac-related surgery in the United States, and one of the first in the world. But let's step back from the technical medical achievement for a moment and think about what this story really means. Hale Williams was operating in a society that told him at every turn that he was inferior, that black people were intellectually incapable of mastering complex scientific and technical fields like medicine. He faced discrimination in getting his education, in finding places to practice, in gaining the respect of his white peers. He had to build his own hospital because the existing medical system wouldn't let him and his black patients through the door. And Then, when faced with an impossible surgical challenge, when every textbook and every experienced surgeon said that what he was considering was medical suicide, he trusted his own judgment, his own skill, and his own courage. He looked at James Cornish dying on that table and decided that the life of a young black expressman was worth taking the risk. Worth breaking the rules, worth doing what had never been done before. That's not just medical skill, that's moral courage. That's a statement about the value of black lives at a time when American society was actively communicating that black lives had minimal value, and Williams didn't stop with that one surgery. After the Cornish operation, Williams continued to build Provident Hospital into a premier medical institution. He trained dozens of black physicians and nurses, providing opportunities that existed almost nowhere else in America. In 1894, President Grover Cleveland appointed Williams as chief surgeon of Freedman's Hospital in Washington, D.C., one of the few hospitals in the country dedicated to serving black patients. Williams accepted the position and spent the next 4 years transforming Freedman's into a modern medical facility. He reorganized the hospital's structure, improved hygiene and surgical practices, established pathology and bacteriology laboratories, and created an internship program to train young black doctors. The hospital's mortality rate dropped significantly under his leadership. It was making Freedman's into a center of excellence that could compete with any white hospital in the country. But Williams' tenure at Freedman's was not without conflict. He clashed with the hospital's administrators over his insistence on merit-based hiring and promotion. He wanted to hire the best doctors regardless of their connections or political affiliations. While the administrators wanted to use hospital positions as political patronage, Williams also faced resentment from some in the black community who felt he was too demanding, too focused on matching white standards rather than celebrating black achievement on its own terms. These conflicts revealed some of the complicated dynamics of being a black pioneer in a white-dominated field. Williams was constantly navigating between proving that black medical professionals could meet white standards and advocating for black institutions and communities. In 1898, Williams returned to Chicago and to Provident Hospital, continued his surgical practice, performing innovative operations and training a new generation of black surgeons. He married Alice Johnson in 1898, though the marriage would later end in divorce after years of strain. Williams never had children, dedicating his life almost entirely to his medical work and to advancing opportunities for black physicians. In 1913, Williams received recognition that had been denied to black physicians for the entire history of American medicine. He was invited to become a charter member of the American College of Surgeons, one of the most prestigious medical organizations in the country. He was the only black surgeon among the founding members, a lonely distinction that highlighted both his individual achievement and the continued exclusion of black medical professionals from the mainstream of American medicine. Williams continued to practice and teach into his 60s, though his later years were marked by increasing frustration with the persistent racism in American medicine and disappointment that more progress hadn't been made in integrating medical institutions. Williams suffered a stroke in 1926 that left him partially paralyzed. He retired from active practice and moved to Idlewild, Michigan, a resort community that had become a popular vacation spot for middle-class black families. There, in relative isolation, one of the great surgical pioneers of the 19th century spent his final years. He died on August 4, 1931, at age 75. His death was noted in black newspapers and in some medical journals, but the mainstream press gave it little attention. The man who had performed the first successful cardiac-related surgery in America, who had founded one of the first integrated hospitals in the country, who had trained generations of black medical professionals, died in relative obscurity. For decades after his death, Williams's achievements were known primarily within the black community and among medical historians, who specialized in African American contributions to medicine. Mainstream medical history textbooks often omitted him entirely or relegated him to footnotes. When cardiac surgery was discussed, the focus was typically on white surgeons from the 1940s and 50s who developed open-heart surgery techniques using the heart-lung machine. Williams's pioneering work in 1893 was forgotten or dismissed as a lucky one-off rather than the breakthrough it actually represented. This erasure was part of a broader pattern of minimizing or ignoring Black contributions to American medicine and science. It wasn't accidental. It was a deliberate choice, made by educators and historians and publishers, to tell a version of medical history that centered white achievement and excluded or marginalized Black innovation. The consequences of this erasure are profound. When medical students learn the history of cardiac surgery without hearing about Daniel Hale Williams, when young Black students interested in medicine don't see examples of Black surgical pioneers, when the narrative of medical progress is whitewashed to exclude the essential contributions of Black physicians, it shapes people's understanding of who can be a doctor, who can be a surgeon, who can make breakthrough medical discoveries. It perpetuates the lie that medical excellence is primarily a white achievement, when the truth is that Black physicians, despite facing enormous barriers, have been at the forefront of medical innovation throughout American history. Fortunately, this is changing. In recent decades, there's been increased recognition of Williams's achievements. Medical schools now teach about his pioneering cardiac surgery. History books include his story. There are scholarships and awards named in his honor. The Daniel Hale Williams House in Chicago, where he lived, has been designated a National Historic Landmark. Provident Hospital, though it has moved locations and changed over the years, still exists and still serves Chicago's communities. These are important steps, but they're not enough. Williams should be a household name, as famous as any of the great surgeons and medical pioneers. Children learning about medical history should hear his story alongside stories of Louis Pasteur and Joseph Lister and William Halsted. His achievement on that July night in 1893 should be celebrated as one of the defining moments in the history of surgery, because that's exactly what it was. One man, facing impossible odds, armed with inadequate tools and incomplete knowledge, looked at a dying patient and decided that the impossible was worth attempting, and he succeeded. Think about what that surgery room must have been like. It's the heat of a Chicago summer with no air conditioning. The dim light from oil lamps and windows, primitive anesthesia that could kill the patient as easily as save him from pain. The rudimentary instruments, nothing like the sophisticated surgical tools we have today. The complete absence of the monitoring equipment that modern surgeons depend on to tell them second by second how the patient is doing. The knowledge that if anything went wrong, there were no backup options, no emergency protocols, no way to call for help from more experienced cardiac surgeons because there were no more experienced cardiac surgeons. Williams was inventing cardiac surgery in that moment, making decisions with no precedent to guide him, trusting his understanding of anatomy and his surgical skill and his belief that James Cornish's life was worth fighting for, and he succeeded. Against all odds, in defiance of all conventional wisdom, he succeeded. James Cornish walked out of that hospital and lived for decades. That's not just a medical miracle. That's a testament to human courage, brilliance, and determination. And it's a reminder that progress, real progress, often comes from people who are willing to challenge the status quo, who refuse to accept that things can't be done just because they've never been done before. Williams couldn't have known for certain that his surgery would succeed. He had good reasons to believe it might work based on his knowledge and experience, but he couldn't know. He had to act anyway, had to trust himself and his skills and his judgment. That's what pioneers do. They venture into unknown territory not because success is guaranteed, but because the potential reward, in this case, a human life, is worth the risk. Medicine has advanced enormously since 1893. We now have open-heart surgery performed routinely with bypass machines that take over the function of the heart and lungs, allowing surgeons to operate on a still heart with far greater precision and safety than Williams could have imagined. We have heart transplants, artificial hearts, stents, and medications that prevent and treat cardiac disease in ways that would seem like science fiction to Williams. But all of that modern cardiac medicine rests on a foundation that Williams helped build. His willingness to open James Cornish's chest, to explore what was inside, to repair damage that conventional wisdom said was unrepairable, opened a door that subsequent generations of surgeons would walk through. Every patient who survives cardiac surgery today, every person who receives a bypass or a valve replacement, or a heart transplant owes something to Daniel Hale Williams and to his courage on that July night in 1893. That's his legacy, not just the specific technical achievement of one successful surgery, but the proof of concept that the heart could be touched, operated on, repaired. That what seemed impossible was actually possible if you had enough skill, enough courage, and enough belief in the value of human life to attempt it. And there's another dimension to Williams's legacy that's equally important. By founding Provident Hospital, by training Black physicians and nurses, by proving that Black medical professionals could achieve excellence when given the opportunity, Williams challenged the racist structures that dominated American medicine. He didn't just save individual lives through his surgical skill. He opened pathways for thousands of Black medical professionals who came after him, people who might never have had the opportunity to practice medicine if Williams hadn't created institutions where they could train and work. That's a different kind of life-saving, one that echoes across generations. Before I close, I want you to imagine something. Imagine you're James Cornish on that July night in 1893. You've been stabbed. You're lying in a hospital bed, struggling to breathe, feeling your strength ebbing away. And a Black doctor comes to you and says, "I can try to save you, but it will require an operation that's never been done successfully before. I'll have to open your chest. I'll have to work on your heart. You might die on the operating table, but if I do nothing, you'll definitely die." What would you say? Would you trust this doctor? Do you give him permission to attempt the impossible? James Cornish said yes. He trusted Daniel Hale Williams with his life. That trust was rewarded. Now imagine you're Dr. Williams. You know the odds, you know the risks. You know that if you fail, if Cornish dies on your operating table, it will be used as evidence that Black surgeons aren't capable of complex procedures. That you reached beyond your abilities, that you should have known your place. But you also know that if you don't operate, Cornish will die anyway. What do? Williams chose courage over caution. He chose the possibility of success over the certainty of failure. He chose to believe in his own abilities, even when the entire medical establishment said what he stared. Was attempting was impossible. That choice, that moment of decision, changed medical history. If this story inspired you, if it made you angry that you weren't taught about Daniel Hale Williams in school, if it made you think differently about medical history and about the Black pioneers whose achievements were systematically erased, then I need you to do something right now. Hit that like button. It helps this video reach more people who need to hear Dr. Williams' story. Subscribe to Crowned Black Heroes and turn on notifications, because every week we're bringing you stories like this. Stories of remarkable Black individuals whose brilliance and courage changed the world, but were nearly erased from history. And drop a comment below. Tell me what you think. Did you know about Dr. Daniel Hale Williams before watching this video? What other Black medical pioneers do you think deserve recognition? How do we ensure that future generations learn the complete, accurate history of medical achievement in America? I want to hear from you. Let's build a community committed to uncovering and celebrating these essential stories. Thank you so much for watching. Thank you for caring about truth and historical accuracy. Thank you for being willing to learn about the pioneers whose names you should have been taught but weren't. Dr. Daniel Hale Williams deserves to be remembered not just during Black History Month, but as a central figure in the history of surgery and medicine. Share this video. Tell his story. Make sure the next generation knows his name. And join me next time as we uncover another incredible story of Black excellence that history tried to erase. Till then, stay curious, stay inspired, and keep fighting for a world where everyone's contributions are recognized and celebrated. Peace.